Wait, 3, 2, 1. We are live to the audience. Over to you, Nitin, sir.
Good evening, everyone. I am Dr. Nitin Abhyankar from Pune. And on behalf of Indian Chess Society, I welcome you to this wonderful webinar, which we are going to conduct today. This is all about tobacco, smoking, and vaping. And with the background of a recently happened World Anti-Tobacco Day, this is of a great relevance. And I think, if I'm not wrong, ICS webinars history, we are touching this topic for the first time. I work in Pune with an NGO called PACE, which is Prevent Addiction Through Children's Education. And I've been actively involved in this for the last more than, say, 14, 15 years. We have created 2 films, 2 songs, and a lot of interactive videos which go to children. And by God's grace, and with the help of 150, 200 volunteers, we have reached out to more than 8 lakh children in Maharashtra. This is about hitting people early before tobacco or smoking or vaping hits them. And that's what we believe, that prevent addiction through children's education. So we target the teenagers between 8, 9, and 10. And to start the scientific deliberations, I must invite today, I have a wonderful panel. The first person I will invite is Dr. Gopi Khilnani, sir. Can I have his slide, please? Yes. Sir has been a chairman of PSRI Institute of Pulmonary Critical and Sleep Medicine. He was formerly a professor and head of Department of Pulmonary Critical Care and Sleep Medicine in AIIMS, New Delhi. He's got huge number of affiliations, achievements, and awards. Overseas Fellow Critical Care, Mount Sinai Medical School, USA, ex-member of Executive Committee, Indian Society of Critical Care, Fellow, and Global Governor of American College of Chest Physicians in USA, member of the Expert Committee of ICMR on Electronic Cigarettes, Fellow of the National Academy of Medical Sciences, Zonal Chairperson for the Indian Chess Society for the North Zone. He's a past president of NCCP, member of Technical Advisory Group of WHO Global Air Pollution and Health, member of Senate IIT Delhi from 2017 to 2019, and of course, more than 250 publications, and I think thousands of videos to his credit. So he probably keeps on coming with something new every day. And who better than Dr. Gopi Khilnani, sir, who was our scientific chair for our NAPCON, to talk about smoking, tobacco, and vaping. Over to you, Khilnani, sir.
I hope my slides are visible.
Yes, sir.
Yes.
Just share in a full screen mode.
Yeah. So, good evening, everybody. And good evening, my fellow faculty panelists. And thank you, Nitin, for giving a general introduction. And big thank you to Dr. Amita and Indian Chess Society for giving me this opportunity to talk about tobacco to vaping, the menace to mankind. We are looking forward to a vibrant evening with the full knowledge of tobacco, which is so important not only to pulmonologists but humankind at large. So I have been granted 25 minutes to discuss, give an overview of this problem, and I'll start with the problem. Tobacco kills up to half of its users. So half of the people who start smoking tobacco will be somewhere responsible for their death. There are more than 7 million people die each year. Isn't it staggering? And 6 million deaths due to direct tobacco use, and almost a lakh deaths due to second-hand smoke. Now, the passive smoking, as you see in the picture, causes significant morbidity and mortality. 12% of adult deaths worldwide are attributable to tobacco smoking, and worldwide prevalence of smoking is actually not going down, and those aged more than 15 years or older, as many as 22% of people are smoking. So this is the extent of problem. If you talk about India, 29% of Indian adults are using tobacco some way or the other, out of which 19.9 crores are actually chewing tobacco, not smoking tobacco, and 12% are actually smoking tobacco. And there are approximately 11 to 12% adults are current smoker, and more than 10 lakh deaths per year in India are due to smoking or tobacco related. Now, this is just to scare you. And smokeless tobacco, as I said, as many as almost 20% of the adult population is using. Now, tobacco is not new. I don't want to go into the history of BC and all those things, but if you look at the number of sticks in terms of millions of tobacco being used from 1880 to 1890 up to 2000, there has been exponential rise. And why this is so? Recently, after the Second World War, the females thought that we are equal. No doubt, they are joining BSF, they are joining army, but they said in smoking also, which was much less among the females. Now they say we are equal, so smoking among the females is rising and they are becoming equal. So the health issues, and we'll be talking about pregnancy and fertility at a later stage, they are also increasing among women. I'm not going to tell you the type of smoking in India, the worthless talking. We know that there's a cigarette, BD, shisha, tobacco chewing, hookah, cigar, and all those things. And hookah, which as I was growing, I thought it is very relatively safe because it passes through water, and it actually originated from South and Middle East of Asia. And I had the occasion to go to Cairo sometime 15 years back, and everybody was using what is called shisha. The markets were full of variety of fancy shishas, but it is equally toxic. Somebody, if he thinks that when this vapor passes through water, it gets cleaner, that's not true. All the toxics. On the contrary, what you put in the hookah is tobacco is an uncontrolled quantity, so it is actually more harmful in cigarettes. I wouldn't be spending a lot of time on harmful effects because this August gathering knows about it. If you talk about cancer, talking from larynx to oropharynx to esophagus to trachea to leukemia to stomach, pancreas, kidney, colon, cervix, breast, every cancer in the body is caused by or enhanced by smoking. And of course, lung cancer, I don't have to talk about, we all know about it. But strokes, blindness, cataracts, oral periodontitis, aortic aneurysm, coronary heart disease, COPD will be spending, and even osteoporosis and hip fracture. So there is a lot to talk about. And passive smoking, as I said, as many as 1 lakh deaths in India are caused by passive smoking, the ladies and children who are actually not smoking. Now, the contents. What does tobacco contain which tobacco smoke contains, which is so harmful. 4,000, more than 4,000 toxic chemicals are there, and some of them are mentioned there. Some cause cancer, like benzene, vinyl chloride. Some cause poisonous gases like ammonia, toluene, and butane, and carbon monoxide. And there are toxic metals also, cadmium, arsenic, and so on. And so total, more than 4,000 chemicals. Some are known, some are not known, are, are contained. And then there are some neurochemical effects are also there. Now, why people get kick out of nicotine? Because dopamine causes pleasure, it suppresses the appetite. The norepinephrine, which causes arousal, acetylcholine, which causes arousal, and cognitive enhancement. People think that when they want to do some academic work or something what require concentration, they use. There's a glutamate which causes memory enhancement, and serotonin, which is mood modulator, and there's an endorphin which reduce the anxiety. So there are some temporary benefits, you can say, of smoking. If you talk about lung cancer, when I was studying, we were studying that 90% of the lung cancer is caused because of tobacco smoking, and only 10 to 15% were occurring in non-smokers. But today, uh, as much as 40% of smoking, especially in Delhi and North India, is caused by atmospheric air pollution. That is not the subject of the day. But nevertheless, the the lung cancer, smoking remains one of the causative factors which is most important. Now, secondhand smoke is not far behind. It causes in children brain tumors, lymphomas, of course, asthma is a very important disease which is enhanced by secondhand smoke and lower respiratory tract infection and variety of malignancies. Now, COPD. As I was studying, the 90% or 80 to 90% of COPD was caused by smoking. Today, the 50% is caused by atmospheric air pollution. Unfortunately, now the susceptible smoker who develops COPD, his lung function goes down like this. However, should he stop smoking, it never goes back to normal. It slows down. The the uh, the decline in FEV1 slows down. This is Fletcher and Peto's graph, which were done in the London Transport Worker. So COPD now is becoming second leading cause of death in some states like Rajasthan. Overall in the world, it is a third leading cause of death. Now, it's amazing that till the first study which which pointed towards causation of lung cancer by tobacco smoke came in 1950 only. In Second World War, everybody was smoking. It was a fashion to smoke. And if you see movies of 1950s and 60s, Indian movies, Bollywood movies, मैं फिक्र को धुएं में उड़ाता चला गया. We all loved Devanand, singing that song on screen. And then first Surgeon General report of smoking and health came only in 1964, which said that smoking is harmful. Why I'm telling you all this? Today the people have started vaping, thinking that it is a safe thing. And I think it will take 50 years or 100 years to generate solid evidence that vaping is harmful, but I'll come to it later. Now, coming to the second part of my deliberation, that is vaping, called electronic cigarettes. It is also called electronic nicotine delivery devices, called ENDS. What is vaping? It is relatively new. These are one of the fastest growing products in America today. And they entered US market in the year 2007. It offered an attractive alternative to conventional smoking. And since 2014, the e-cigarettes have become the most popular tobacco products used among the youth population. And 21% of the high school children in US and 5% of the middle school children were using vaping in the year 2021. Now, these are battery operated devices that heat the liquid usually containing nicotine producing vapor, and e-cigarettes actually started from China in the year 2023. Now they come in a shape that you get a feeling. It could be a pipe, it could be a cigarette-like stick, and it comes in the variety of forms, even in the pen drive form, which one can keep in the pocket. And people are using it because at places where smoking is prohibited, at public places, there is no law which prohibits this, and I'll come to it later. So people are using it left, right, and center. Now, how does it work? There's a light which lights up when the person inhales. There's a battery. There's a microprocessor which controls the heater and the light. There's a cartridge which contains nicotine in propylene glycol, which is an organic substance. And when the person inhales, it gets microprocessor gets activated, and this battery would produce vapor. And person inhales it like he's smoking BD or cigarette and gets that feeling. And the nicotine content of the e-cigarette is usually much higher than what is contained in the cigarette. And propylene glycol and propylene and other organic substance, they are toxic to the respiratory system and the other systems. And there are flavoring. It comes in various flavors, strawberry flavor, jasmine flavor, and so on and so forth. So, how does it work? It works because it gives the freedom of smoking anywhere and everywhere, and person think it is safer, and that is being promoted as real cigarette. And they all kinds of promotion gimmicks are there, and that attracts the youngsters. Now, the salient feature of e-cigarettes, what's called that, as I said, 21% of high school children and 5% of middle school children were using. And WHO report showed that use of ends among the smoking users increased by a factor of 5. So therefore, use of ends by minor doubles their chances of starting. So come to think of a young lad, 12, 13 years old, who uses electronic cigarette. He gets nicotine, he gets addicted to nicotine. Next time he is unable to get an electronic cigarette, he resorts to smoking. So it is becoming a significant health problem. 2019, there was an expert committee was constituted under the chairmanship of Dr. Reddy. I was a part of it, and we threadbare discussed the literature and came out with a white paper which was published in the Indian Journal of Medical Research, submitted to the government of India, and which this paper, the white paper, after reviewing the literature, suggested that electronic cigarettes should be banned in India. Sale and use of, and the government of India within a month, they came with an ordinance, which has become an act now that sale of electronic cigarettes is, sale and use is banned in India, but we know that it is available in the grey market and it is being used, but nevertheless, thanks to the government for using them. Now, there are various trials which have been done. The proponents of electronic cigarettes say that they can be used as smoking cessation tools. Somebody who is hooked to the tobacco, cigarette or BD smoking or hookah smoking, instead this is a safer way of using nicotine, and through which it can reduce the stop the smoking. But that actually doesn't happen, and I'll tell you later. Now, this was a randomized trial where 7.3% with were using nicotine with e-cigarette, 5.8 with patches, and 4. This is the result. So 7.3% with nicotine e-cigarettes were able to abstinent, 5.8 with patches, and 4.1 with placebo e-cigarette. So there was no, actually not significant difference between the e-cigarettes and the placebo and the nicotine patches. The e-cigarettes with or without nicotine were modestly effective at helping smoker to quit the similar quit smoking. So there are other studies also, the efficacy and safety of electronic cigarette as tobacco cigarette substitute, a prospective 12-month randomized trial, smoking reduction and abstinence in 300 smokers, not intending to, and this was the result. The three arms were there, and the result was a decline in cigarette per day use in electronic cigarette users. Smoking reduction was dominated in 22, 10, and 12 weeks. Complete abstinence from tobacco smoking was documented in 10, 8, and so there was not significant difference, and I'll come to it later. The conclusion was in smokers not intending to quit, the use of e-cigarette with or without nicotine decreased cigarette consumption, but it did not stop the addiction. That is what I'm trying to put across. And this is a meta-analysis of e-cigarettes in 38 studies, irrespective of interest in quitting, which has not shown significant benefit in quitting. So e-cigarettes can only have a positive effect if they are embedded by regulatory framework. So regulation concerning the children and adolescents, public funded research on long-term use of e-cigarette, reduction of nicotine content in e-cigarettes to make them less addictive, and FDA this is announced. The industry is not primarily interested in public health. That's a problem. The harmful effects of e-cigarettes, I have seen a case of alveolitis. There have been reports of ARDS. There has been animal experiments when the electronic cigarettes are given to rats and they are sacrificed. There are carcinogenesis that is being, and also there is a passive exposure to vapors can in pregnancy severely affect the health of both mother and fetus. So nowhere they are safe. The US FDA have demonstrated the presence of diethylene glycol on some meds, which can lead to mass poisoning and deaths if inadvertently substituted for propylene glycol. There were additional presence of genotoxins and animal carcinogens in e-cigarettes, which is a matter of great concern. The last part of my talk, and I will finish fast enough, tobacco control and quitting smoking. That is extremely important to a pulmonologist. What are the symptoms of tobacco addiction? The physical symptoms are strong craving, increased heart rate, shortness of breath, coughing, headache, nausea, appetite. Behavioral: frequent use, secretive behavior, social isolation, using tobacco in prohibited setting, neglecting responsiveness. Psychological are in the form of anxiety, mood swings, stress, depression, lack of motivation, and obsessive thoughts. These are the physical effects of respiratory diseases. Of course, we know all about it. Mental and cognitive effect. Now, how do you make a person quit smoking? It is an uphill task, and that is what is shown in this. And but important thing is that like in COPD patient, if the person quits smoking, there is significant reduction in mortality. So there is sufficient evidence if the person stops smoking. And of course, the mortality reduction with smoking cessation is 36%, statins 29%, beta blocker 23%. So the best way to reduce the mortality reduction cardiovascular is smoking cessation. Now, how soon you get benefit of smoking cessation? Within 20 minutes, your heart rate and blood pressure drops. Within 12 hours, your carbon monoxide level in the drops to normal. Within 2 to 12 weeks, your circulation improves, your lung function increases. Between 1 to 9 months, your coughing and shortness of breath decreases. Within 1 year, your coronary heart disease risk is about half that of a smoker. Your risk of stroke is reduced in 5 years' time that of a non-smoker. In 10 years' time, your risk of lung cancer falls to about half that of smoker. It does not come to the non-smoker. In 15 years' time, your risk of coronary disease is that of a non-smoker. So why I'm telling you that there is no, it's never too late. And how to quit smoking? What are the most efficacious way? You have to look at the motivation. What is the motivation? Pressure, hope, acceptance, pain, fear, and rejection. Acceptance, we seek acceptance, we avoid rejection. Now, one of our major preoccupation is to be accepted by our peer or social group, much to our behavior. The two most important risk factors for smoking initiations are friends who smoke and parents who smoke. Now, the other risk factors are lower socioeconomic status, lower education, and why do we keep smoking? Because of rejection and pleasure, and also because of the withdrawal symptom. Now, I'll have to go a little quick. You have to tell your patients that if you continue smoking, your life will be cut down, your lung health will go down. And same thing, I generally draw this with my own hand and tell my patients as to if you quit your smoking, your COPD, you are going to live longer, your COPD will become progress will become slower. Now, your word has impact. There's a lot of responsibility on the part of doctor to spend some time. If you the coronary intervention, you save lives. I don't need to go into the data, but this is the final thing. The 5 A's, that is ask, advise, assess, and then arrange for follow. Now these are the results. The cold turkey technique, as compared to nicotine replacement therapy, is equally good or equally bad, you can say. If you use e-cigarettes in a controlled environment, they are 60% more successful. However, if you use medical support and medication combined with specialist support and prescription medication, that means the intervention by the physician, 225% more successful. So that is what need to be understood. And of course, you have patches, you know all this, that there is a patches, there are tablets, there are gums, and there are sprays. So electronic ends as a tobacco cessation. Although some smokers claim to have cut down smoking while using end, the total nicotine consumption seems to be unchanged. E-cigarette seems to have rather similar or even weaker efficacy. There is no difference in size of e-liquid vials. In 4 countries survey carried out in United States, the United Kingdom, Canada, and Australia, 70.4% of the study subjects reported to have used ends as a way to reduce the smoking. The International Association of Study of Lung Cancer does not recommend use of e-cigarettes for treating nicotine dependence even in cancer patients due to the absence of sufficient evidence of their efficacy. The Indian Medical Association considers ends as an unhealthy and disguised form of tobacco addiction with serious long-term health effects and unfit to be used. So this is the conclusion. The tobacco is an addiction and harmful substance. Physiologic dependence and addiction very common. Most people start smoking in adolescence and due to peer pressure and social reasons. All forms of smoking is harmful. E-cigarettes lead to increased tobacco smoking. So let us say no to all forms of tobacco. Ladies and gentlemen, Dr. Nitin and my panelists, thank you very much for your patient hearing, and I'll be most happy to join the discussion. Thank you very much.
Thank you, Dr. Khilnani sir, for such a wonderful, exhaustive, and a very, very illuminating kind of a talk. I think one simple message here is, from Sir's talk has been the Fletcher Petto curve. And at whatever point in time a smoker wants to quit, it's never too late. So that's the number one message. The other message, I think, which is indirect and it is driven through all his lecture, is that every time you consume nicotine, the receptors in brain are increased automatically, and because they are increased, the brain craves for more nicotine. So I think the simple message that he gave about e-cigarettes is very important, that you cannot de-addict in the truest sense people with e-cigarettes. So I think, and that's why that data, which is so disappointing, people thought e-cigarettes was the way out of nicotine addiction because so many less poisons in e-cigarettes and only glycerol and then substituted diethylene glycol and kind of things. But at the same time, I think all said and done, we actually are not truly doing de-addiction by the so-called nicotine replacement therapies, including e-cigarettes. Before I introduce the panel, let me thank, first of all, Dr. Amita Nene, who's been brilliantly, phenomenally conducting these ICS webinars for last 56 weeks, if I'm not wrong. And I think this is today attended by close to 2000, if I'm not wrong, Aditi, if you can correct me if I'm wrong. 1955 was the last number which I saw. So
Yes, sir,
huge.
you're right.
Yeah. So the huge number is attending, and we thank you, Aditi from Lupin also for that. So Amita, Aditi, thanks a lot. We also thank our new president and our secretary, Dr. Rajadhar also. So with that, I will request so one by one, I'll introduce the panel. Dr. K. Satish, the new winner from Bangalore, the Royal Challenger. And I'm sure he'll be very happy to listen to that because his son is also a cricketer. So, MD DNB Fellow, British Thoracic Society, FRCP UK, is currently the Chief Pulmonologist at Manipal Hospital, Millers Road, and Chest and Maternity Center, Bangalore. Presently President of Karnataka Pulmonary Association, past President and presently President of, past President at position, Indian Academy of Allergy, Board of Directors, HIV MAI, Principal Investigator for many global studies and so on and so forth. Huge number of publications. His area of interest is asthma, COPD, ILD, sarcoidosis, TB, and HIV. And of course, delivered guest lectures at thousands of occasions, if I'm not wrong. The second person I would love to introduce is Dr. Rishita Bhatt. She's a consultant pulmonologist at Kailash Hospital in Dehradun in Uttarakhand. She did her MBBS in Himalayan Institute of Medical Sciences and MD from Government Medical College in Chandigarh. She did her senior residency in AIMS Rishikesh, Uttarakhand. Assistant professor now in Shri Guru Ram Medical College. Yes, and she did a European diploma in adult respiratory medicine in 2020, invited as a speaker in various national conferences and workshops, and more than 15 publications in national and international journals. Welcome, Dr. Rishita, on this panel.
Thank you so much, sir.
Thanks, Rishita. Welcome here. The next one is a friend very close to me, both physically as well as close to my heart. Dr. Yuvaraj Badhe. He is MBBS, DNB, FCPS, TDD, and FAIH. He is a consultant in pulmonary medicine, Mauli Hospital, Multispeciality, Talegaon, near Pune. Assistant professor in DI Patil Medical College of Medicine, MB Pune. And he has publications in national and international journals, special interest in COPD, bronchial asthma, and bronchoscopy. And of course, MMC accredited speaker. So welcome, Yuvraj. Wonderful having you today here with us. And last but not the least is Dr. Saranya Selvakumar, MD, DNB, IDCCM, FCM. She's a consultant interventional pulmonologist, sleep medicine specialist, and a critical care specialist in Erode, Tamil Nadu, India. One of the early members to start advanced interventional pulmonology, one of the first one to do an EBUS and a cryotransbronchial lung biopsy in Erode, performed exemplary work during COVID pandemic. She started with a 55-bedded COVID hospital in Erode and headed 200-bedded COVID hospital in Tirupur. recipient of the Hindu Star Doctor Award 2021, Roundtable Erode COVID Warrior Award in 2022, and Tamil Nadu State IMA Women's Doctor Wing Award of Excellence in 2025. So I think I have convinced you enough about the excellence of this particular panel. Welcome, Dr. Saranya, to this meeting.
Thank you, sir.
I think I hand it over to Dr. Khilnani, sir, to introduce me. I really don't need much.
So, it's a greatest pleasure, Nitin, to introduce you. I can't call you by full name, Dr. Nitin Abhyankar. His immediate laurel is organizing an amazing NEPCON in Pune at a 6-week notice. It is a record in itself. Sorry.
Yes,
Can you hear me?
yes, sir. Yes, sir.
Yes.
You're right.
There is something wrong. Yeah. So, Dr. Nitin Abhyankar is the MD and AD EDARM, consulting pulmonologist and HOD pulmonary medicine, Pune Hospital and Research in Pune. He has 100 plus presentation and more than 25 publications. He is a life member of ICS, IMA, ISCCM, FIAB 2023. And most importantly, I want to tell you, he is a singer par excellence and also a poet. And my first interaction is with him was in Pune, and he's an amazing friend, an amazing person to be in touch with, always helping to everybody. And I'm sure, I hope with this introduction, you will not ask me difficult questions. So, and of course, we have so many youngsters who would be contributing to this cause, and thank you, Nitin, for being there with all of us all the time. Thank you.
So thank you for your kind words, but I don't think you have any difficult questions left in your lifetime. I think you can only ask difficult questions to others, if at all. So let me ask Dr. Satish, the first question is, what is the so-called definition of a pack here? How does it differ from smoking index? And how do you really adjust the pack year calculation when you're talking from a cigar to a pipe to a bidi or a hookah? I don't know. I mean, so the ball is in your court, Dr. Satish.
Thank you. Thank you. And good evening, everyone. And excellent talk by Professor Khilnani. Always enjoy speaking to him and talking to him. Of course, thanks, Amita and Nitin. We have an excellent panel here, and we will be discussing about tobacco and its side effects and how to make patients give up smoking, which is a challenge always. And Professor Khilnani mentioned already about various aspects of tobacco, smoking, chewing side effects, and also how to give up. Now, we have to have some measurement in quantifying how many cigarettes or how many bidis or how many pipes one smokes. This will give us a lot of information and insight into how much nicotine and how much other substances which are present in the cigarette smoke or in the bidi or in pipe is going into the lungs and causing harmful effects on various systems of the body. So either we can mention how many cigarettes per day for a number of years for our practical purpose in our daily routine in examining the patient. The first thing that I have after name, age, and sex is about exposure to cigarette smoking and biomass fuel. And then I start, taking the other symptoms and signs. So that's so important in pulmonary medicine. So what is this one pack here that we all, talk about? So it's just one of the parameter or a unit used to measure the smoking exposure over a period of time. If you're thinking about 5 years, 10 years, 20 years, or even 1 year. And it is defined as smoking one pack is equal to 20 cigarettes per day for 1 year. So if you're smoking, if your patient is smoking 20 cigarettes per day for 1 year, it's 1 pack years. So like that, if you have patients smoking more than 1 pack, then it's more than 1 pack is 2 packs and go on. So you can have several examples like this. 1 pack per day for 1 year is 1 pack year. 2 packs per day for say 15 years is 15 pack years. So similarly, if you have somebody is smoking just about half pack, which is about 10 cigarettes per day, is about 3 pack years. So this is about the pack years that's used. Mostly this is useful in investigative purpose. Like for example, if you are doing a study on COPD or cancer, what is the amount of exposure of smoking in cardiovascular disease and so on. Whereas smoking index is something which is another way of measuring the number of cigarettes one is smoking and the exposure of nicotine into the body. So this is used in some countries like India and other countries. These are mainly used for the other forms of tobacco like BD and pipes and so on. Can also be, it's very simple, can also be used for cigarettes as well. For example, a person who smokes 10 cigarettes per day for 10 years, it's easy to say 10 into 10, is 100. If somebody is smoking 25 years, who smokes 25 BDs for 20 years, so again, calculate into 25 into 20 is 500. So it's just multiplying the number of BDs that somebody is smoking or somebody is cigarette smoking into a number of years. So it's simpler than the pack years that one does. So this is mainly used for the pack year formula for using cigars, and pipes is slightly different. It can be extrapolated. So we all know they contain cigars and pipe contains different forms of tobacco and either inhaled in a different way and in different quantity. So there are general equivalents which are there available. Like for example, 1 large cigar is equal to 1 pack of cigarettes. That is about 20 cigarettes. So if somebody is smoking 1 large cigar, then 1 small cigar is about 3 to 5 cigarettes per day. Then 1 gram of pipe tobacco is equal to 1 cigarette. So if you have all these calculation, you need not by heart and keep it just for knowing academically that how much, and one can also measure them with these kind of estimates that you have. So smoking index, then smoking with cigars, smoking with pipe, can also be with BDs. One can measure. This is what I have to say in brief about smoking index, as well as patients who have who can be calculated for the pack years. It's a simplified way.
Great answer, sir. And I think that clarifies a lot of doubts in a lot of youngsters' minds. Ritisha, I'm coming to you with this next question is, what pack year threshold will you use as a risk of developing COPD or lung cancer significantly increases? And how does the smoking index correlate with the disease severity in COPD patients?
Thank you for the question, sir. The critical threshold that we take for pack years for developing COPD is like 10 pack years. And this data has to be interpreted with a pinch of salt, because in a study which was published in the European Respiratory Journal, what they did was they looked into the Copenhagen heart study population, and they looked at patients who smoked less than 10 pack years, and they followed them for another 5 years. And they saw that down the road, 23% of patients still develop COPD. So the critical threshold today is considered at 10 pack years, but I would say any amount of smoking is not safe. Then, sir, for lung cancer, the critical threshold of pack years is considered to be 20 pack years, and that is what most of the guidelines are using for screening lung cancer with low dose CT. And here I would like to add that it is the duration of smoking which is more important as compared to the amount of smoking you're doing when it comes to the adverse effects in severity of COPD and lung cancer. To answer the second part of your question, sir, how the smoking index is related to the severity of COPD. So once there are studies which have seen the severity of COPD and they have used the Bode scale for that. We all know the Bode scale, where it uses the BMI, the degree of obstruction as indicated by the FEV1, then the dyspnea as per the MMRC score, and the exercise capacity as per the 6-minute walk distance. It is a score which is taken for the prognosis as well as the severity of the disease. And what the study saw that the smoking index was directly proportional to the Bode index. So the more the people smoke, the more severe the disease in them was. Thank you, sir.
Wonderful answers both, and I think what your message seems to be is that it's not necessarily the number but duration, a little more inclined toward duration. Of course, the numbers matter. If somebody
Numbers do matter, sir, but the duration is absolutely
but
important.
the duration is probably more impacting the both COPD as well as cancer risk.
Yes.
Let me come to Yuvaraj. Yuvaraj, what are, in your opinion, various respiratory effects of smoking? You are on a mute, Yuvaraj. You will have to unmute.
Sorry, sir. Thank you. Smoking, that is the smoke that gets inhaled, and that leads to the adverse effect on the lungs health. It causes the harmful effects on the function as well as structure of the lungs. When we consider respiratory system, then we have to start from the nose to the alveoli. This when this smoke that causes the oxidative stress, and this oxidative stress leads to the inflammation, and then there is imbalance between proteases and antiproteases, and that leads to the lung injury, and that lung injury in the small airways, alveoli, and this leads to airway airflow limitations. And this means if the smoking is in young age or adult ones, then that produces the symptoms like cough, then there is a phlegm, and there can be reduced lung functions and maturity also. So declining in the lung functions because of this inhalation of the smoke, which contains so many more than 4,000 carcinogens present in the cigarette smokes and the tobacco smokes. So when we consider the harmful effects of the smoking on the lungs, then we can say whether there can be chronic complications as well as acute complications. When we think chronic complications, this smoking and causes the COPD, which is the leading cause of death worldwide as well as in our country. Then also the lung cancers, these are the chronic complications. But at the same time, this smoke reduces the immunity. It is cellular immunity as well as humoral immunity. And whenever we get any acute exacerbations of COPD or asthma, we presume that they are because of some underlying infections. So this smoking that causes the defect in the lung immune mechanisms, and then this is acute respiratory illnesses, maybe because complications may be because of the smoking due to this reduced immune responses to the bacteria and viruses. So these are the respiratory harmful effects of the smoking.
So ranging from, say, smokers' bronchitis right up to reduced immunity, susceptibility to infections, COPD, and eventually a malignancy. You have explained the range so beautifully. And I'll move on to Saranya. Dr. Saranya, welcome. What are, in your opinion, the cardiovascular effects of smoking?
As was already discussed, smoking, there is sympathetic stimulation in smokers. There's a release of free oxide radicals. There's decreased nitric oxide synthesis. So what we have noticed is there's higher incidence of systemic hypertension in these smokers. Because of the arterial stiffness also increases. As a result, there's a drastic increase in number of acute coronary events in these patients, sometimes because of plaque rupture, sometimes because of coronary spasm. And also studies have clearly shown the incidence of abdominal aortic aneurysm is 5 times higher in these patients. Also, as already known to us, peripheral vascular disease, smoking is one of the leading causes. In Buerger's disease, which can even lead to critical limb ischemia leading on to amputation, smoking is the #1 cause. So for primary treatment in these patients itself is smoking cessation. And also nicotine studies have shown nicotine leads to atrial fibrosis leading on to atrial arrhythmias. So there are varied complications right from systemic hypertension to acute coronary event to arrhythmias in smokers.
Yeah, I think wonderfully put. In fact, I remember my best friend's father was a smoker, and one day he had to get amputated. And after that, my father quit smoking. I mean, so that was the story. So as bad as that. So we can't even forget a very so-called trivial looking peripheral vascular disease, but can be devastating for somebody who's smoking for a long enough time. So I think you have beautifully put the cardiovascular range of cardiovascular effects. Sir Khilnani, sir, we come back to you. What are the psychological effects of smoking? How does smoking affect pregnancy? These are two little different questions. Outcomes and fetal development.
So I think I've already described the psychological effects
Yes.
of depression, anxiety, palpitation, sleep. If somebody smokes 2 hours, within 2 hours of going to bed, his sleep is likely to be disturbed. There may be difficulty in going to sleep. So I'll be focusing on, and I avoided talking about pregnancy because that I knew that question will come to me. First and foremost, the fertility, both for males and females, goes down. There's a fertility problem. Second one, that somebody who smokes and becomes pregnant at that time, there are more chances of fetal abnormalities, congenital abnormalities. There are more chances of ectopic pregnancy if you talk about the first semester. But more importantly, it affects the placental circulation. As it affects our atherosclerosis, as Dr. Selvakumar described very beautifully. So it affects the placenta also. The result is that there's more chances of placenta previa, there's more hemorrhage, bleeding, antepartum hemorrhage, as well as postpartum hemorrhage. There are more chances of abortions. If you talk about fetus, there can be something called infant death syndrome, the sudden death of that can also occur, and also there is a higher chances of intrauterine growth retardation. And also there are so many health issues which occur in the child who is born to a mother who has been a smoker during pregnancy, and that includes several of the diseases, including the more chances of infections also. So there are long-term studies showing that. And no amount of smoking is safe for any pregnant lady, and it is also true that whether the first trimester, second trimester, or third trimester, it is not that it is unsafe in the first trimester and one can smoke during the second trimester. Also, I would like to emphasize, having special interest in the electronic cigarette, there is upcoming evidence that even the electronic cigarettes have the similar impact on pregnancy. And as I said, it will take years or maybe 50 years to come out with solid evidence about electronic cigarette. As with the tobacco smoking, it has taken centuries for evidence to come forward.
Wonderfully put, sir. I mean, very, very precise and very, very to the point, and at no point in time underestimate the harmful effects of any form of nicotine inhaled, both in the pregnancy as well as to the fetus also. Satish sir, I come back to you again, and now I'm asking you a question which is like beyond all this. So respiratory, cardiological, pregnancy, psychological, we already talked. What other effects of smoking? What other harmful effects of smoking?
Okay, thanks, Nitin. I think Professor Khilnani in his introduction mentioned about passingly about the other effects of tobacco, nicotine, so on, and the other systems of the body. So as clinicians and especially pulmonologists, we tend to focus on mainly respiratory, saying, okay, it causes cancer, it causes COPD, it aggravates pre-existing lung disease, and major probably like Saranya mentioned about hypertension, ischemic heart disease, and so on. So the smoking effects is on every system in the body. It's not only the major systems, of course, are cardiac and respiratory. But for example, if you take neurological problems, it is strokes, very common in smokers, and patients have also noticed decreased memory power, decline in cognition, Alzheimer's, depression. All these are also common in patients who are smoking. And if you take malignancies, there are hematological malignancies, malignancy of the oral cavity, malignancy of esophagus, stomach, colon, and in smokers, in ladies, cervical cancer, and also bladder cancer, kidney cancer. So you name many of these cancers. It's not just the respiratory system. The smoking is associated with every cancer in the body. Maybe just the skin's cancer, not mentioned. But it also has effects on the skin, especially for young people. We can always, come out and say, look, it causes, aging quickly. So you are looking, you may be aging about, you may be aged about 30, 35, but you are looking like 50 is because of your smoking. That probably is appealing, okay, health. And also mentioned about sexual dysfunction in young people. This is also one. We already mentioned about infertility. The other thing is about talking about erectile dysfunction and saying that it causes erectile dysfunction. So better give up smoking. The other aspects are DVTs are common, pulmonary embolisms are common. It has effects on endocrine system, the thyroid, the diabetes. Patients become insulin resistant, and also on the eye, it has the effects on cataract. Patients can have premature cataract, also have some macular degeneration. Osteoporosis, very common. We see in patients with COPD, osteoporosis, and easily fracture. Easy fracture things are very common. And of course, the gastrointestinal, we already mentioned about the cancer, but peptic ulcer, rupture of the ulcers are also very common, and also on the colon. So Nitin, practically every system in the body, taking from skin to the brain to internal organs, to the smoking has its effect. So it's for us to stress on patients why they should give up smoking, because one day or the other it will show up. And as Professor Khilnani showed, half of smokers or tobacco users will develop ultimately some form of smoking related mortality in patients. Thanks. Thank you.
So beautifully and so comprehensively said. I mean, this is remarkable, because every single system, every single organ seems to be involved one way or the other. And almost or rather never favorably. There's nothing which is good happening apart from that dopamine, hit that you are getting for a few seconds. And after a some time, even that is lost. So that's the sad part of the story. That and the craving gets better, worse and worse. So Ritisha, I come to you. Please tell us a little about smoking related ILDs and how do you diagnose and how do you manage them?
Sir, regarding the smoking related ILDs, the ILDs that we are concerned about first is respiratory bronchiolitis interstitial lung disease, or the RBILD. So the RBILD, the profile of the patient would be somewhere around 30 to 50 years of old age, who has a history, who's currently smoking or recently quit and has a history of smoking more than 30 pack years. And that patient presents to us with dyspnea, cough, wheezing, sure. And then the patient, when we auscultate, we can find crackles in that patient, and we get a PFT, we would see a mixed ventilatory defect in that patient, and the DLCO will show us moderate reductions. So these are the kind of patients where we can suspect an RBILD. In these patients, we'll go ahead and get an HRCT chest done. In HRCT chest, findings indicative of RBILDs are centrilobular nodules and GGOs. Then we can have emphysema, we can have air trapping. So while looking at the patient profile and the HRCT, we can think that we have RBILD, but for the confirmative diagnosis, we would like to go ahead with the bronchoscopy, where we would like to do a BAL to rule out other causes of ILD, the infectious causes we like to rule out. And for the confirmative diagnosis, we would like to have a transbronchial lung biopsy or a cryobiopsy. In the biopsy on histopathology for RBILD, what we'll see is pigment-laden macrophages in the first and second order respiratory bronchioles. And what is hallmark of RBILD is that it is bronchiocentric. So we'll see these changes which are very much near the bronchus only, and the rest of the lung apart from that would be normal, or it will have emphysematous changes. So a similar profile will also be of our DIP, that is deep squamous interstitial lung pneumonia. And many people believe that RBILD and DIP are not separate entities, but a spectrum of the same disease. So in DIP, what we'll see is we'll have smokers. In DIP is also common in non-smokers, especially where in children who have inborn errors of metabolism or drug-induced also. So 90% of patients can be smoker, 10% can be non-smoker. In DIP, the CT findings will have they will have nodules, but they would be random nodules, and they would have GGOs. In RBILD, the findings are mostly upper lobe predominant. In DIP, the findings are lower lobe predominant. When we come to the histopathology, in DIP, what we see is that we also have pigment-laden macrophages in the alveoli, but here the changes are not bronchocentric, they are more diffuse. So that is indicative of DIP. Then the third that we've talked of, how am I going to manage RBILD? So first and foremost, of course, the smoking cessation. We would ask the patient to quit smoking, then we will wait to see the results. If the patient still has moderate to severe disease, then what can be tried are corticosteroids like prednisolone in the dose of 30 milligram per day, and it can be given in tapering doses up to 9 months, and then it has to be stopped. And if we want to give the patient something for steroid sparing, then we can try azathioprine. Of course, these are rare kind of ILDs, and we do not have a documented treatment for them. When considering for DIP, the protocol is same. We ask the patient to quit smoking. And if if the patient still doesn't benefit from that we can give them a trial of steroids. And if they is still not benefiting from that, then we can go ahead and give them steroid-sparing agents like azathioprine or cyclophosphamide. The last that I've talked about is pulmonary Langerhans histiocytosis, and that's a cystic lung disease. And we see the patient profile, we see it is generally younger patients, 20 to 40 years of age, and they are exclusively smokers. And they present to you mostly with pneumothorax, or sometimes it is incidentally detected when they are getting a chest x-ray or a CT scan of the chest done. And when they come to you, they are dyspneic because of the pneumothorax. When we get an HRCT, there are some few findings that we need to keep in mind. One would be that we would get numerous bizarre shaped cysts in these patients. The costophrenic angle would always be spared in these patients. The third would be we would get some nodules, which would be still at 2 to 10 millimeters, and they would be mostly upper lobe predominant, and the lung volume would be preserved in these patients. So these are hallmarks of cystic lung disease which point towards PLCH. And if we get this, and the patient is a young boy, he's a smoker, then we should take him for a bronchoscopy where we'll do a BAL. For PLCH, what we'll do is we'll send an immunostain for CD1A and CD207. If more than 5% of the stain is positive, then it is indicative of PLCH. Of course, to treat the disease, first and foremost is smoking cessation. And still, if after that we are not able to treat the patient, then of course corticosteroids have to be given starting from 30 milligram per day in a tapering dose. And still, if the patient has resistant disease, that what has been tried in literature are some disease chemotherapies like claridipine, which have been given, but of course under supervision and at expert centers. So these are the 3 ILDs that we need to keep in mind when we're talking about smoking related ILDs, sir.
Beautifully. You have done such a wonderful job of putting a 30-minute lecture into 3 minutes. Greatly done. It's not easy, frankly. Wonderful.
Thank you, sir.
Thumbs up to you. Yuvaraj, we are asking you one of the most difficult questions. What are the differences in the side effect profile of a cigarette, cigar, pipe, and BD? Which is worse for the lungs?
Sir, 2 questions we will take together. But before that, we need to understand what is cigarette, what is BD, what is cigar, what is pipe. So just a BD, which is commonly used in our country, that is one that tendu leaf, and inside it that tobacco is there, that is raw tobacco. And it is that raw tobacco is wrapped in that tendu leaf, and it has no filters as compared to the cigarette. It has a little bit tobacco that is maybe better than the BD, and it has a filter. Then we come to cigar. That cigar is bigger than the cigarette, and which has no filters, and large amount of tobacco is there in the cigar. And when we see the pipe, that tobacco rests in the some bowl, and then there is a pipe. That pipe may have filters. But when we see that all these 4 things contains tobacco, they have nicotine, there is a smoke. So all the adverse effect because of the smoking will have in this, or all 4 things. So some says that the pipes and cigars, they are less harmful, but it's not like that. The size of cigar is more than the cigarette. Means Satish sir said that 1 cigar is equal to almost 1 pack of cigarette. Means we can say that the cigars are more dangerous than the cigarettes. When we compare to BD and then cigarette, cigarette, then BD is 8 times more toxic than the cigarette. Means these have more tar than carbon monoxide content, as because of the combustion of this leaf and this tobacco. And all 4 have all the adverse effect, like airway obstructions like COPD, and even they can exacerbate the bronchial asthma also. In case of these pipes and cigars, there is like a biomechanics of popping. Means what they do, they inhale that smoke and keep in the mouth only, closing the this larynx. That smoke remains in the mouth only. So whenever that smoke touches, that causes the malignancy. So that can cause a malignancy of the lips, malignancy of the pharynx, malignancy of oropharynx, lung cancers. Even it will cause malignancy of the pancreas and bladder. So as compared to all, BD is 8 times more harmful than the cigarette, and cigars are just as compared to the cigarette. It means 20 cigarettes is equal to 1 cigar. So they are more dangerous than the cigarette. And the side effect profile is because of the nicotine content that can cause addictions, and that lead to many adverse effect, cardiovascular adverse effect, or there can be heart rate variability problems. Then this smoke that contains tar and carcinogens that lead to different types of cancers, and the smoke can lead to airway obstructions, COPD. So this is the way we should, means tobacco in any form that causes the harmful effects, whether it is BD or cigarette or cigar or pipe.
Yeah, I think the simple message here is that nicotine is what you are craving for. That gets you addicted. Nicotine is as addictive as heroin. But all the harmful chemicals, those 4,000 chemicals which Khilnani sir talked about, and more than 200 known or unknown carcinogens which are present, they are the ones which are eventually causing the damage. And therefore, I think one should not say this is less harmful, go for pipe, go for a cigar, go for a BD, nothing like that. Almost all of them are equally harmful. One little less or more, it really doesn't make much of a difference. Saranya, Selvakumar, Dr. Saranya, is second-hand smoking harmful, and what are its effects on the health in the adult population, particularly women and in children?
The second-hand smoking, otherwise known as passive smoking, is equally as bad as smoking. Basically, this is the smoke that fills our office spaces, our restaurants, and public spaces. So we really don't know what is the safe level of exposure in second-hand smoking. Let me divide this, the impact in fetal period, neonatal period, pediatric population, and adult population. When the mother is exposed to second-hand smoking because of parental smoking, ultimately it leads to premature deliveries and low birth weight. Similarly, in the neonatal period, there's a higher for babies who are exposed to secondhand smoke, there's a higher incidence of SIDS or sudden infant death syndrome. The reason being this nicotine being a strong irritant can somehow lead to an airway compromise and leading to SIDS. And as far as children, especially when parents are smokers, these children's immune system and lung is just developing. So when you get them exposed to this kind of smoke and harmful products, what happens is we ultimately we end up seeing their FEV1 lung capacities are much lower than children who are from whose parents are non-smokers. So these children are also, they have frequent infections, respiratory infections, right from otitis media to asthma exacerbations to pneumonia. And one another correlation, what they have noted is there's higher incidence of obesity in these children who are exposed to secondhand smoking, and their activity is much less. As far as adults are concerned, as for any smoker, when you get exposed to secondhand smoke, there's a 30% higher incidence of cardiovascular disease, a 20% higher risk of obstructive airway disease, and one of the leading cause of lung cancer in non-smokers is passive smoking. Also, as far as ladies, when their husband smokes, what we have noted is infertility rates are much higher in these women. So it's time, next time if your friend or spouse smokes, it's time to say bye and walk out of the room.
Yeah. Wonderfully put, very beautifully put. I think the next question is, of course, to Dr. Khilnani sir, and I think it is his favorite question. Does the hookah bars, which are so popular, the shishas or hookahs, whatever you want to use them, I don't know the difference between the two, so please explain that also. Does it always contain tobacco? And please tell us about the side effects of hookah with or without tobacco.
I have to ask you, why did you choose me for this? I don't go to cover. But anyway, so it is, as already talked, hookah with tobacco is not safer than I have already talked in my
It doesn't really filter things out. I mean, it's not there.
Those who want to say that, okay, it is safer because it passes through the water, has not been found to be true in studies. It's equally harmful. Another thing is that in hookah, what you do, you put tobacco like this, so there's an uncontrolled amount of tobacco that is burnt. So it is likely to be, to my mind, more harmful. Another thing is that it's a usual practice that one hookah is a community hookah smoking. It's usually not one person. So there is an unhygienic way of transmission of infection from one person to other. That is one thing. The other question that you asked me, hookah or shisha, which is used in uh, parties and bars and gatherings, and I told you I went to Egypt and I saw a person for 2 hours. He continuously was using shisha in a restaurant. There were no restrictions at that time. So it is not necessary that every hookah or shisha contains tobacco. There are other flavoring things and other substances are also burned. So the adverse or toxic effects will depend upon what you are burning. But having said that, all the burning things are hydrocarbons. They are harmful substances. There is no literature which says this particular substance is more harmful, but suffices to say that uncontrolled amount of high concentration of burning material, depending upon what flavor you are using, goes into your lungs, and it is very, very harmful. There are studies which are done. So that's what has become fashion in our youngster parties, and no parties is there without vaping and shisha. So that's what I know.
So one way or the other, whenever you're burning things, noxious particles are getting generated, and noxious particles are going to be harmful to the lungs. That's probably the shortest answer that you
One
can.
thing I want to say, comment upon since we are talking about this pipe smoking is said to be little safer than I'm not saying that one should. The reason is that have you seen pipe smoker how they smoke? They never inhale deep. They keep it as a fashion, and there's always a shallow breathing that they do. So it causes damage to the oral mucosa, but it causes lesser damage to the lung. That's what the literature says.
Of course, can't really justify doing that.
No, nobody is justifying that.
I think I'm going to summarize. Next two questions I have in front of me are mainly related to vaping. One is to Dr. Satish. Does it really contain nicotine? What is vaping, and what does it contain? I mean, just a quick summary, because I think Dr. Khilnani has already covered that in his talk.
Absolutely right. And
But
he
it's
showed
worth repeating, sir.
So vaping is simply inhaling vapor into the lung through e-cigarette, electronic cigarette, or a vaping device. And Professor Khilnani showed a beautiful slide diagram of what it contains. It contains a cartridge, it contains a tank, it contains a battery. So it's a nicely done equipment where you inhale and then it gets activated and then heats the liquid, the e-liquid, and then it forms the vapor. And I know, as we discussed, it's also a type of tobacco smoking, even though it contains less amounts, but it's still harmful, not really recommended for smoking cessation clinic, in smoking cessation therapy. It contains definitely nicotine. It contains propylene glycol, and it also contains many flavors, which are sometimes youngsters use them as saying that it's nice to inhale these flavored cigarettes, e-cigarettes, or devices. So it definitely vaping is harmful. Vaping causes similar problem, may not be the same as that. Not recommended by any organization saying that it should be a tool for smoking cessation. It simply means that inhaling vapor through e-cigarettes.
Could I emphasize something?
Yes, yes.
Yes, please.
Because I have reviewed the whole thing in great detail. The biggest disadvantages are two. One, that it carries an uncontrolled amount of nicotine. average one cartridge contains nicotine, which is equal to 20 cigarettes of nicotine. And with each puff, no one knows how much nicotine is going into the system. And another thing is that it's not only one hydrocarbon. There are several volatile hydrocarbons which are there, and the experiments have shown that there are cancer changes in the rat lungs when they inhaled the same thing. So long-term effects we really don't know, because it is
And the
relatively,
data will keep emerging.
yeah, they will keep emerging, but certainly the second-hand smoke also harms, and of course in pregnancy also it harms.
And they may contain some psychoactive substances as well, which is like extracts of cannabis and so on. So it is.
No, it depends. That you want to adulterate it with that, that's fine.
That's right. So that's the
that is sorry. When I was talking about hookah, some people in hookah will put marijuana or some other stupefying substances. I think that you wanted to ask, that I skipped. So some people, you can do anything to,
I think there are lot of questions coming from the audience about EVALI. That is vaping related ARDS-like phenomenon. So I think I'll ask the first, I think 2 or 3 people can comment on this EVALI part of it. Yuvaraj, you can talk about it, and then Saranya also, can you talk about a little bit of EVALI? So Yuvaraj, we'll start with you. You are muted.
It's when when the patient presents, like it's a clinical presentation, and means it can be acute or subacute respiratory illness, and actually it is and that can lead to acute lung injury also, and that patient may need oxygen support or non-invasive ventilation or even mechanical ventilation also. Sometimes it's a means it's injury, and it's a new thing, and it's difficult to differentiate it from other illnesses if it is acute injury. So history of e-cigarettes or this vaping is important in evaluating these patients with lung injury secondary to e-cigarettes. So there can be respiratory symptoms, there can be GI symptoms, then there can be constitutional symptoms. So different ways, and there is different clinico-pathological presentation of this lung injury secondary to this vaping or e-cigarettes.
Dr. Saranya, you want to add something to this?
Yes, sir. Basically, EVALI it's a diagnosis of exclusion. So patient can exclusion. So patient can have acute or subacute symptoms. Patient may just present to you with cough, breathlessness that has been progressing over a couple of weeks, or it can have an acute presentation like sudden breathlessness, tachycardia, desaturation. So primary thing over here is history. You will have to elicit history of vaping in the last 17 days, which is very difficult because they might not be willing to reveal the history, given that most of the times it's procured in the gray market. So when patient presents to you in an acute setting, say with sudden breathlessness, desaturation, tachycardia, increased respiratory rate, it is like any other picture is like any other viral illness. So then you look at an X-ray which shows bilateral infiltrates, a CT which shows bilateral ground glass opacities. Then you go for routine blood investigations like your total counts, lung function test, liver function test. There's no test that is clinching that would tell you this is an EVALI. So basically, you evaluate for all other common causes like a viral illness, say for a COVID or an influenza, when all other diagnosis has been ruled out, especially bronchoscopy to rule out infections. So you've ruled out other viral illnesses, you've ruled out other infections. then you attribute it to EVALI. So once you come to a diagnosis of that, treatment is mainly supportive. So for someone who's desaturating, it will be oxygenation. For someone who is worsening, again put him on a ventilatory support. There's no specific antidote. However, steroids are tried for these patients. Prior to that, we will have to definitely rule out infections. So on steroids, gradually they show improvement. So once patient is discharged, the main point that you have to remember is they have to stop vaping henceforth. Otherwise, that is the primary advice that we will have to give them when they are getting discharged. So other common reported, there are case series that have been reported with vaping like lipoid pneumonia, acute eosinophilic pneumonia, and also organizing pneumonia has been associated with vaping. These are all scattered case reports, but all of them are right now under the purview of, under the broader term called EVALI.
Yeah, I think very, very nicely put, very nicely summarized. Thank you for that. Khilnani sir, we come to you with this million-dollar question of how do you counsel patients to quit smoking or vaping? Some tips from your side.
Thank you very much for asking me this question. I might have failed number of times. And first and foremost, I ask them, majority of time these are patients with either asthma or more often COPD, who are quite disabled because of that. First and foremost, I ask them, do you want to quit? And I can tell you quite often they decline. That no, they don't want to quit. Now, if they want to quit, then only I'll move ahead and do it. And then I actually challenge them. It's very difficult, and if you have willpower, then say yes. Otherwise, they would say, okay, yes, willpower and blah blah blah. And then actually, I take out a plain paper and pen. Since you have asked me my tips, so I am telling you. And I am quite used to making this Fletcher and Pito, and I actually make it with the pen and tell them that, look, you are here now. If you continue smoke, you will go down like this. If you stop smoking, then this will slow down and you will live longer and with lesser of the symptoms. And then, of course, this cold turkey technique, I tell them you have to someday. Then they say, okay, I'm smoking 10 cigarettes. From tomorrow, I'll reduce. Then I'll promise them that, look, I am telling you from the experience and the literature that reducing number of cigarettes will not help you. If you want to quit, you have to quit on a particular day. It could be your birthday, your wife's birthday, your child's birthday. Usually for a male person, a daughter's birthday sounds much striking to them than wife's birthday, unfortunately. But that is what is true. And then I tell them, see, what do I do? If I have craving, then I tell them, okay, you can start taking tea or coffee, start doing something, or engage yourself with somebody, pick up a phone, talk to somebody, or anything. And before that, throw away everything: a lighter, cigarette, leftover cigarettes, whatever you have. And after that, if you have uncontrollable withdrawal symptom, then come to me. If you And believe me, Nitin, I'm sure you have also done that. So many of my friends and patients have actually quit for life 20 years back because 15 years back. But some don't, are unable to do that. Then I tell them, if you have withdrawal symptom, then only I'll prescribe you some medication.
Correct.
At the outset, I do not prescribe you.
Yeah, I think one of the most important messages which emanates from you is deciding on a date and possibly committing it to the world. It's worth advertising. Even if you give it in the newspaper, it is worth it because then you are sort of committing yourself to it. And if the commitment fails, then the next question which goes to Dr. Satish is, what are the most effective pharmacological treatments for smoking cessation at this point in time available in India? And please elaborate on selection, choosing, and dosing, and some are available, some we want and are not available. So kind of things. Everything to you, sir.
Yeah, thank you. I think I must start from saying, what Professor Khilnani said. That's only if there are withdrawal symptoms. First, you motivate them and then give them all these, what you mentioned, tips about it. Don't have an ashtray in your room. Don't go and meet your friends who are smoking, and don't buy cigarettes in packs. So all those kinds of things are equally important. And most important is, spoken by a doctor, spending few minutes of time, whether it is pulmonologist, whether it is internal medicine, general practitioner, or a diabetic specialist, whoever it is, they all see the specialists for various diseases. So they must spend at least few minutes, and it will have an impact. Definitely, they're going to think about it seriously. And when they make the choice and they come back and say, as Professor Khilnani said, that I have withdrawal, I'm unable to give up, I may reduce QDI of smoking, but unable to do it. Then you motivate them, continue to motivate, and then say that there are nicotine replacement therapies are available. Nicotine replacement therapies are in the form of in India, what is available is the lozenges, the gums, the nasal spray. These are available. The lozenges and the gums are available in the form of 2 milligram or 4 milligram, easily available. And now we also have the nasal spray. There used to be inhalers, which is no longer available, not in India, of course. And I use mainly a replacement, either gums or lozenges, or I've started using the nasal spray, which is supposed to be quick acting, and it helps. 6-stop is one that I use. Then if they fail to do in spite of this, then you also can add oral medication. The oral medications are 2, bupropion and varenicline. Bupropion is available, which was again had some setback, but it's one which is available because also used for depression and other psychiatric illness. The varenicline, which is the Champix, used to be available, but no longer available. Last, I think, 2 years, it's not available in India. And they are saying most likely it'll come back after another submission to the drug controller, because there seems to be some content like nicotinamide or something which is more than what is required. So it'll come back. I used quite a lot earlier, and now I use bupropion, which is mainly 150 milligram. You start using once a day for 3 days, and then double it up, twice daily. You get a SR, you get few brands which are available, and then use it for about 7 to 12 weeks. Many of them who have psychiatric illness like depression, and definitely helpful. There are some contraindication like epilepsy and so on. You take care of that. So basically it stops at 2 lozenges, gums, and nasal spray, and bupropion, and varenicline not available. And you can also non-pharmacological treatment you can try with psychotherapy and biofeed mechanism, whatnot. Everything is available. There is an app which is available, which patients find it easy to go through. So all these are available. We must make an effort to use every possibility to make patients give up smoking. And my theme or my objective is to keep calling them, telling them, you come every month at least to see me, even if you're not able to give up smoking. And ultimately, once you give up, don't even come back. You're not required to come back unless you have a lung issues. Then you do a regular checkup. So you need to be in touch with your healthcare provider, and that will help patients with it. Thank you.
Ritisha, your insights into all these, because nicotine replacement therapy is one component of it, bupropion is another, and varenicline, which I loved once upon a time, now not available. So I think, your take on all this, the good, bad, ugly with each of them.
So in the nicotine replacement therapy section, I would like to add that in September 2022, the Indian government added nicotine replacement therapies in the list of essential medicines. So they're very readily available now. So in nicotine replacement therapies, first we have the nicotine patches. So the advantages of the nicotine patches are that it has the ease of use and you have a steady state of nicotine delivery. So they come in three doses, that is 21 milligram, 14 milligram, and 7 milligram. That's step 1, 2, and 3. So if somebody is smoking more than 10 cigarettes per day, we start with the 21 milligram patch. And then after 6 weeks, we can step it down to the 14 milligram, and after 2 weeks to 7 milligram. The disadvantage of the nicotine patch is one, that it can cause you skin irritation and rash, and the other is that it can cause you vivid dreams, insomnia. So what people do is that they take off the patch in the night, but that has to be taken with a word of caution, because once you reapply the patch, it takes at least 30 minutes to 3 hours for the nicotine concentration to begin again. And what we can do is we can rotate the site where we are putting the patches so that we don't have the irritation. We cannot use more than one patch per day at the same time. The second therapy that is available in the Indian market are the nicotine gums, as sir has already mentioned. So if somebody is smoking after getting up within the first 30 minutes, so he has to start with a 4 milligram nicotine gum. And the disadvantages of using the gums are that, patient can have mouth irritation, they can have soreness of the jaws, then they can have nausea, they can have hiccups. And the advantages there is that unlike the nicotine patch, as per your cravings, you can modulate the dose of nicotine. So if you have cravings, you can take it more. But the disadvantage is that if you're wearing dentures or you have dental work, then it becomes very difficult for you. And there's a certain technique of, chewing it and parking it between your gums. If you're not doing it right, then it can also cause you a lot of GI side effects like heartburn and nausea. Then thirdly, which are available are lozenges, and lozenges are also available in 2 milligram and 4 milligram doses. So somebody who's smoking first cigarette in the first 30 minutes of waking up, we start with the 4 milligram dose. And the advantage of lozenges is over the gum is that people with poor dentition and dental dentures also, they can use this thing. The side effects, of course, are the nausea, the heartburn that we have, the irritation of the mouth. And of course, as sir has rightly mentioned, the inhalers are not available in India, but we do have the nasal spray, which has around 0.5 milligram of nicotine, and we use one spray in each nostril, and that can be used per hour. The side effects are then, of course, it has throat irritation, rhinitis, nasal mucosa congestion, and they're not supposed to be used with somebody who has rhinitis or who has polyps. And the advantage, of course, is that it is readily absorbed and it is the fastest form of nicotine that can be delivered to us. So this is about the nicotine replacement therapy, sir.
Nitin, if I can add,
Please.
the side effects of all what Ritisha mentioned is very common in those who do not want to give up smoking.
Of course, sir. Rightly said.
They have an excuse always to come back and say, slight irritation is, is common. So, or a poor, mouth sore and things like that, very common. Those who do not want to give up, they'll always come up and say, no, it doesn't suit me.
So Yuvaraj, very frankly, as a person who's working in this field, I don't really believe that nicotine replacement therapy is de-addiction, because person is addicted to nicotine and you are continuing to giving nicotine. So what's your take on this?
Sir, yes, means whatever they are smoking in any form that contains the nicotine, but that is uncontrolled mode of delivery of that nicotine. And what we are giving in nicotine replacement therapy, that is a small amount of nicotine, and it is delivered in controlled form, whether it is lozenges or it is gums or transdermal patches. If we need it in means if there is any craving, we can give it lozenges or gums. But if they we can give as a transdermal patch that will give constant release of nicotine. So it's means who wants really wants to quit smoking, and this nicotine replacement therapy will relieve that intense craving of smoking because of the nicotine. This means we have alternative methods to deliver the lower doses of nicotine at a controlled rate, and that's why it will not have any that adverse effect of nicotine on various systems of the body.
in an uncontrolled way. And plus minus, of course, so many toxins which are less. Khilnani sir wants to say something, please.
I just want to share. Sorry, it
Yeah.
has been amazing discussion. So if I could share my experience, in my experience, nobody has been able to quit smoking the nicotine replacement, because whenever the nicotine or they is not available, or you are not, as Dr. Nitin said, that you have to get rid of addiction, not the nicotine. Surely, I believe that nicotine is less harmful than cigarette, because it contains 4,000 chemical substances about which we know that they are very harmful. But I have not seen anybody who's using nicotine for a very long time. Ultimately, they revert back to smoking. Those who quit, they who I mean, it's my personal experience that those only quit by cold turkey technique. They just stop. At best, some tranquilizer they take, and gradually they can. This is my personal view. Not that I am against nicotine. I am not against nicotine. If somebody wants to use it, fair enough. But my experience has not been too good.
So Saranya, we want you to now conclude. How do you strategize this whole thing? What psychotherapy, nicotine replacement therapy, and things like bupropion, varenicline, in which order, which sequence? Where do you put them?
Sir, as already said, one size will not fit all. So we will have to have an individualized structured treatment plan for each of them. As Sir had already told, some of them smoke because of peer pressure, some of them smoke as a coping mechanism. In low socioeconomic status, the pattern is different. In higher socioeconomic status, the pattern is different. So basically, we will have to have an individualized treatment plan for each of our patient. Again, this will be dependent on the gender, the sex, and the socioeconomic status. As Satish sir had already told, sit with the patient, talk to them with empathy, not like a convict. Talk to them with empathy. Speak to them about the different options that are available, different therapies that are available, and give them that quit date. Ask them to slow down and gradually stop by that quit date. So basically, therapy, it is a combination of all three factors: pharmacological, behavioral, and social. Link them to link them to other patients who want to quit, who've been trying to quit, so that they can join together and have a social support group as well. So you have pharmacological therapies along with behavioral therapies, along with some social support, along with support from your clinician, so that this abstinence is permanent for the patient.
Fantastic. I think holistically put together as best as we can. And I wish the varenicline is available, because it's possibly one of the most effective partial antagonists that I've come across, with a well-structured molecule. So whatever the limitations which were there, bupropion actually was Velbertin, which was an antidepressant, and then it was accidentally discovered that bupropion also is in people who start using it as an antidepressant, they quit smoking for whatever reason, without realizing that they are quitting smoking. They don't like it anymore. Whereas with varenicline, my experience was wonderful, because when I prescribed it, after 2 weeks, patient simply said, whenever I smoke, I feel like, it's like matti. There's no taste, there's no kick, there's nothing coming out of it, because it's a partial agonist which is constantly present, and therefore possibly it worked better. Anyways, a lot of questions from the audiences, and I'm going to throw whatever is not covered. So EVALI, I think we have covered. If somebody has an idea of how to differentiate from infectious pneumonias, I think, Saranya, you only said that ruling out infections is going to be important, and doing a bronchoscopy and a BAL, maybe a biofire, will sort that out. So I'll quickly go to the next question. This is something which I also don't know what the answer is. How do nitrosamines such as NNK contribute to carcinogenesis in tobacco users? Anybody knows this? I mean, I'm not aware.
So it actually because of the altering the DNA, the mechanism what is understood and described is similar as other toxic carcinogens. So
yes.
So there's nothing great about mechanism about.
So it's a DNA, it's a mutation.
Another thing I want to add, Dr. Saranya gave such an amazing account of this injury with the vaping. I have
EVALI, yeah.
had an occasion to see a few patients with daily, the youngsters are really bad. They are actually vaping too much actually. I can't tell you, I don't have the data, but I have a low threshold for getting a HRCT done for these patients. And if somebody is vaping, which they don't deny, and they are not scared of their parents, at least daily. What daily is concerned, they openly said. One of the when I was instrumental in coming out this white paper, and the government came with the ordinance. 14-year girl came to my OPD with some symptoms, and I asked her, and she said, "I vape." I said, "How can you vape? It is banned." She said, "Uncle, when do you want? Just give me your WhatsApp number and it will be delivered to you." And this was in front of our parents. So, but anyway, that is beside the point. So, if the person is vaping and has got breathlessness and no fever or very little fever, and I will straight away, I have a low threshold for getting a CT done, and I have seen alveolar shadows which are not explained by any infection.
Yeah, that
And I
infection.
do give them systemic steroids.
So very, very nice, very good clue, sir. Somebody vaping too early, too much of breathlessness and a high index of suspicion. I think that's the clue to go for a chest study. There's a question on aldehydes, particularly formaldehyde and acrolein, in the pathophysiology of cardiovascular effect or disease in vape users. Once again,
May I take this one, sir?
Yeah, please.
Yeah, so formaldehydes and aldehydes in cardiovascular disease, what they do is they cause an oxidative stress and they cause endothelial dysfunction leading to atherosclerosis. So that's how they cause cardiovascular dysfunction.
Okay, so you can see so early. I mean, yeah, the vapors are essentially young people, as I
Yes.
assume, and they get
But
significant.
not necessarily.
Okay.
I've
Yeah, I
seen,
think it takes all kind of people to make this
I've
behavior.
seen them all. The thing is that, especially in Delhi, I'm sure in other cities also, you cannot smoke in public places.
Yeah.
People are actually following that, and there's no written law on vaping. And you can do vape and put it in the pocket. You are not burning anything, and so I've seen it happen, and that is one of the reason people use vaping as an alternative to smoking. So
Yeah.
ultimately, it has not led to reduction in smoking.
Sir, so once upon a time it was said that a cigarette is a lot of fire at one end and a fool at the other end. Now there is no fire. There's only a light at one end and a fool
Yeah,
at the other.
yeah,
And therefore you can do it discreetly, isn't it?
yeah. And you can take a smoke and keep it in the pocket,
Keep
and
it
then again whenever you want to. I've seen that. So
this is interesting, heart rate variability and arrhythmogenic potential in adolescents. So again, once again, the aldehydes, Ritisha, sorry, it is the aldehydes which cause this.
The nicotine.
Nicotine by itself will cause this arrhythmogenic potential.
Heart rate increase.
Nicotine.
Yeah.
Nicotine will imbalance the sympathetic and parasympathetic that will lead to this heart rate variability. Means sympathetic stimulation will be there and parasympathetic will be less as compared to sympathetic. That's the effect of nicotine, and so there will be less heart rate variability and arrhythmogenic potential.
Also, sir, studies have shown nicotine causes atrial fibrosis. So that again leads to arrhythmogenic potential.
Okay. Correct. That's right. This is an interesting one. I don't know the answer to this again. Dr. Ganesh from Indore is asking, how does dual use? Why would you want to do dual use? I don't know that. The vaping and smoking impact biomarkers of harm compared to exclusive use of one product. I mean, why would you do a double-blind placebo-controlled trial on this? I have not understood. Anybody has answer to this?
No, there are no answers to that.
uh, this is something again doesn't make much sense to me, but this has been asked by Dr. Prashant. Is NRT effective for passive smokers?
It's not indicated for passive smokers.
Absolutely. I mean, if at all, I mean, you have to beat the active smoker as best as you can, the best possible weapon that you can.
But the thing is that, no. But the passive smoker is not addicted to nicotine.
Absolutely.
Nicotine is going only into the system of the smoker. The non-smoker is getting only the crap.
So if you are too friendly with the active smoker, you have an active smoker by yourself. You are no more a passive smoker. I think nicotine. This is interesting. I don't know whether there is an answer to this. Again, Dr. Tushar asked, are nicotine patches effective in India, given the various weather conditions? So I think absorption related issues, moisture, the heat versus cold, all those. Does anybody has any experience on this? I have not used so many nicotine patches.
Nothing specific, Nitin. I think those are all very minor things which can affect absorption. But ultimately, as Richa said, 21 milligram, 14 milligram, and 7 milligram. In that, even if something is lost, 1 milligram doesn't matter. By all these factors, climate changes, the humidity, the sweaty, no skin, and so on. It doesn't matter. If they are effective. As we discussed in motivated smokers who want to give up smoking and who has withdrawal symptoms, then they are effective.
They're effective, absolutely. How does tobacco use complicate management of chronic diseases? For example, tuberculosis, COPD, and diabetes in Indian settings.
Tobacco,
I think
diabetes, insulin resistance is well known in patients who are smokers. Insulin resistance is well known, and some thyroid dysfunctions are also well described. So that's how tobacco.
All the complications of diabetes will be announced.
They'll be more pronounced actually. And TB and COPD, I would rather one way or the other get the patient off it. If possible, I'll get the patient out of my OPD forever. I mean, if he's not willing to quit for both the conditions, because both are going to be directly injurious to the, COPD as such is going to be getting much worse with this, whether it is caused by nicotine or not caused by nicotine, one way or the other. And tuberculosis, you have a lot of drug interactions along with the added damage of tobacco. So I think one has to get out of it as fast as you can. These are, I think, the youngsters asking this, Dr. Ashwin, the role of digital health tool playing enhancing tobacco cessation in India's resource-limited regions. So is there something like that? Is some e-platform available for?
It's available. The apps are available. There are some apps which are available. And unfortunately, not many active self-help groups are, in India. In Western society, like in London, they have self-help groups. We have for alcohol, like AA. For smoking, not so active, but there are some small groups which are not active. But there are digital platforms, there are apps available. I think the one which is known as, cigarette smoking app, which one of my patients said, it's very useful, and then he was able to quit because of that. I think that maybe having something about it.
Really, there are helplines,
Helplines are available. Definitely.
Every cigarette pack has a number.
Yeah.
Nobody uses. That's a different thing. So,
I think we run a helpline ourselves as a PACE, and we have reached out to as many as around 8 lakh people, 8 lakh children. But very frankly, we don't work because I've worked a lot in this field and I didn't find much buyers. Very frankly, last 20 years, I am declared that if anybody who comes to me for smoking cessation, he'll be seen free of charge. And I'm yet to see more than 10 patients taking advantage of this free service, which I always offer for smoking cessation. So very, very few takers in the truest sense of for this particular activity. But if you hit right people at the right time and influence them, they may not start smoking it itself. And therefore, we chose the 8th, 9th, 10th kind of a group where we go to the schools, we conduct programs which are with a PowerPoint, with a video, and at the end of that, they take a oath that they will not smoke or they will never touch tobacco in any form whatsoever. And our target is very simple. We show the video, we do everything for 1,000 people. 100 people listen to it, 10 people try to act on it, one person becomes successful. Even one life saved is worth it when you reach out to 1,000 people. So that's the simple motto that we follow. And at this point in time, 100 volunteers work in 48 districts of Maharashtra, and we are able to reach out to at least 3,000 to 4,000 new people every week. That's what we are doing. And these are children. These are 8, 9, 10 children. So teenagers who are at a susceptible age, peer pressure, all those, that's the possibly the best age to hit for the smoking cessation.
Nitin, Nitin, sorry, the app for quitting smoking is called Quit for Sure.
Quit for Sure. Okay, great. I think we can put that on and send it to everybody. What is the role of a small airway remodeling in the early stages of tobacco-induced COPD? It's a little theoretical, but I think somebody wants to take this on.
No, nobody knows about it. I don't know. I think we have done.
I think more or less we are done with most of the sensible questions. I think in a nutshell, essentially it's a breathable particle, and because it is breathable, it goes to the smallest possible airways, and therefore, and from that nicotine does go to the bloodstream also. So many particles reach the periphery of the lung, and therefore the small airway damage is maximum. It doesn't stay into the larger airways easily. So that is what probably is the answer. Well, if somebody wants to take this on, one last, Dr. Harsh was asking key radiological differences on HRCT between emphysema changes in smokers versus non-smokers. Any taker for this? I mean, paraseptal, panlobular, panacinar, what kind of emphysema? I really, very frankly, I'm not really into.
My best of my knowledge, there is no information.
Yeah, you can't realistically make much big difference in this. I think we have more or less completed the questions, and the last one, I'm just saying it for the sake of it. How does coexisting conditions like tuberculosis or silicosis complicate the diagnosis of tobacco-related COPD in India? I think once again a theoretical question. They still are coming with a lot of questions. What has been the impact of flavor bans on youth vaping rates?
They're more attractive, the flavors. I believe
Flavors are more attractive.
There are about some 700, 800 flavors of e-cigarettes available. So more attractive to the youth. And that will make them more addictive and get into e-cigarettes.
Yeah. Dr. Harsh asks, and this is a open question for everybody. I don't know the answer. Are there any novel therapies being investigated or to reverse vaping-related lung damage, one way or the other? Do not vape is the most novel thing I can think of. some theoretical questions related to IL-6 and TNF alpha, which I think I'll skip because that's not our focus right now. Yeah. So I think with that, we have covered most of the relevant questions. So what I will suggest is starting with the youngest one, Saranya. I believe you are the youngest one, or Yuvaraj. I don't know. And we'll end with Dr. Khilnani. Your concluding remarks, starting with the youngest. Whoever is the youngest, start first. I am not putting age to anybody.
No, stop smoking, say no to tobacco.
Absolutely. Yuvraj, you're muted.
Muted.
Tobacco,
muted.
tobacco in any form is injurious to our health.
Absolutely. Ritisha?
Don't use e-cigarettes as a means of quitting smoking.
Absolutely. It's a gateway towards smoking rather than gateway out of it, basically. Satish, sir.
Okay. So don't give up as a clinician, and be empathetic and understand why they are not able to give up.
Absolutely.
Very, very important. Keep seeing, don't get irritated. Don't tell them you don't come back till you give up smoking. Keep working on it.
Yeah.
And one day you will succeed. Even if you don't succeed, doesn't matter.
Even if it is a fourth attempt, fifth attempt, as long as the person is willing to do it, we'll keep doing it. Khilnani, sir, your concluding remarks.
I'm not going to say anything technical, but I think I was very, very pleased to hear Dr. Saranya, Dr. Ritisha, and Yuvaraj, and of course Satish. It only tells me that future of pulmonary medicine in India is bright. Listening to them, amazing disposition, and I'm not saying just for the sake of saying. I learned a lot listening to them. Very, very well prepared, very scientific, very evidence based. Very happy, and we are finishing this webinar with a great pleasure, having learned something more than what I knew. And Nitin, thanks to you for being so patient with all of us. Thank you.
So
great
having you.
We will all take it as a great lesson and compliment. And of course, our moderator Nitin, amazingly, for holding on for 1.5 hours, 2 hours. I know you did a good job, Nitin. Thank you.
I must thank the Lupin people first. Amita, you never forget. So she's one of the best. Dr. Samaria, the new president, and Dr. Rajadhar from ICS for allowing us to be here today. And I hope I have learned a lot, and I hope all the people who have attended have learned a lot. With that, it's a goodbye and a good night to everyone. Thank you very much.
Thank you, sir. Good night.
Thank you.
Thank you, sir.
Thank you, Aditi.
Thank you so much, sir. Thank you all. Good night.
Thank you.
Good night.
Thank you. Good night.
Yes. Thank you so much, everyone. So from here, I'm closing the session. Thank you.
Thank you. Thanks a lot.